Thank you very much for introducing me with these nice words. Aerosols are ubiquitous. This was one of the first sentences, the first statements when I visited my first aerosol conference in the early 80s. So it's over 40 years ago. Aerosols are ubiquitous, and this sentence really influenced my professional career until today, and I'm still very interested in all kind of research about aerosols. A journey of 45 years in aerosol medicine in 20 minutes is really challenging. And so I try to do my best and start. So as Gary already mentioned, I started my career in 1980 in the lab of Willi Stahlhofen in Frankfurt. Willi Stahlhofen, I don't know if many of you know Willi, but he was a pioneer in aerosol deposition, aerosol dispersion, and aerosol clearance of the within and from the lungs. And I had the pleasure to work for him more than 15 years. Yeah, that's how I looked 45 years ago. And that was Willi. Willi was a very exciting person and he influenced me, not only with my professional life, he taught me a lot, but he taught me two lessons. One, be curious. And number two, be critical. Don't believe everything that you see in any textbook. And I give you in the next 20 minutes a few examples of being how I was curious, and we were surprised by the results that we received from our work. Because if you do a clinical study or an experiment, you never know what really comes out. If you know what comes out, it's not a new research, then you only reproduce something. And so in 1980, there was a dogma that says all particles which are deposited in the bronchial airways are cleared within 24 hours. And when we did our very first experiments, Gary knows about this kind of work, using radio-labeled aerosol particles, getting them into the lungs, and then in 1 or 2 or 3 days, you hope you get them out again and measure the radioactivity in the lungs. And it was a real doctrine that says after 24 hours, everything what is deposited in the bronchial airways is out of the lung again. And we did experiments after experiment with Willi. We used indium-labeled and gold-labeled and technetium-labeled particles. But surprisingly, we always, when we used the certain particles, we always had about 50% left in the lungs. So it was not true that everything that was deposited in the bronchial airways was really cleared out of the lungs. We had long discussions about this finding with different researchers all over the world, but finally it was our results that we got. So a substantial amount of inhaled particles and deposited particles in the airways are not cleared within 24 hours. This fraction is particle size and material dependent, so the smaller the particles, the more are left in these airways. And these particles are probably cleared by airway macrophages, by cough and dendritic cells. That was the first surprise we had. Then there was this I call it the 5 micrometer doctrine. That you find in many, many textbooks in the pharmaceutical industry, the doctrine that particles which are bigger than 5 micrometer cannot make it into lung. But the biology is never black or white. So 4.9 make it into the lung, and 5.1 micrometer particles are not going into the lung. This cannot be true. So we did a lot of studies with particles, particle deposition, and regional particle deposition. So is it true that 5 micrometer particles, which are bigger, 5 micro, cannot get into the lungs? No, it's not true. This is the deposition as a function of particle size, and you see this is from 1 nanometer to 100 micrometer, and here is 5 micrometer. And you see this is intrathoracic deposition, and intrathoracic deposition at this point has almost a maximum. So it's not true that 5.5 micrometer particles don't have a lung deposition, don't make it in lung. They are. You can deposit these particles in the lung, and you can inhale them into the lung, and they will be. They even will get deep into the lungs. Even 10 micrometer particles are able to get into the lungs. Yes, you're right. I would not use 10 micrometer particles for treatment of alveolar diseases, but nevertheless, there's a substantial fraction of 10 micrometer particles which enter the human airways and the lungs. So also particles larger than 5 micrometer can be used for pulmonary drug delivery. This 5 micrometer doctrine stimulates researchers to make studies with particles which are smaller than 5 micrometer. I made a literature research, I think it was in 2012, and I looked for papers where researchers did lung deposition studies, and I looked at the results. These were all published data with different particle sizes and where the lung deposition was reported. And behind 5 micrometer, there are almost no data because no one uses bigger particles to make lung deposition research. So this 5 micrometer doctrine prevent researchers to make other experiments. Regional lung deposition, again, something that is always very difficult for me to understand. Again, here this is 5 micrometer doctrine again. These images, which we find in many pharmaceutical literature, these images suggest that regional lung deposition is mainly dependent on particle size. Yes, it is dependent on particle size. And here you see particles smaller than 1 micrometer should be used to deposit these particles in the alveolar space. Do we all agree on that? I don't. Because I was involved in the EMA, European Medical Agency approval from Inhale. John Patton and his colleagues, they worked on inhalation of diabetic drugs, and they want to show that these particles makes it into alveolar space. And what they were using were 2.5 micrometer particles, insulin inhalation. And the people from the EMA, when we discussed it in these expert panels, they asked me, hey, why did they use 2.5 micrometer? Because in the literature, everybody can see that you need particles smaller than 1 micrometer to make it into the alveolar space. I said, okay, I make some calculations with the old ICRP 66 model from 1994. And this is a result. When I used a certain breathing pattern, and this is a breathing pattern that you normally see when people inhale through a dry powder system, fast and quick. That's 1 micrometer, that's 2.5, that's 5 micrometer. So it's not true that only particles smaller than 2.5 micrometer can make it into the alveolar space. If you ask the same patient or volunteer to inhale with the same flow rate, but with a deeper breath, maybe like this, then you get 30% in the alveolar region. This is 3 or more than 3 times the amount with the other breathing pattern. And if you ask this patient to inhale the aerosol like a cigarette smoker, very quiet, deep breath, then you get more than 50% in the alveolar space. But always, the maximum is always not 1 micrometer. The maximum is 2.5. So John Patton was right. He used 2.5 micrometer particles to deliver the insulin into the alveolar space. And from this slide, you see something else. And I gave a talk in 1996. And the title of my talk was The Particle Size, the Most Important Factor in Inhalation Therapy. Today, I apologize for this talk because here you can see that the breathing pattern has a much bigger influence on regional lung deposition than particle size alone. So 5 micrometer inhaled with a slow and deep breath has 40% alveolar deposition compared to 8% deposition when the patient is inhaling 1 micrometer particles fast and shallow. So breathing pattern is very important. And this is something I learned when we did studies with real patients. Not with trained patients, with patients, they use their inhalation device when they were at home or when they were in the clinic. So Peter Brandt did a study, and it was also an eye-opener for me. He did a study, and it was published in 2000. That's 25 years old. And he had a very high variability when patients inhaled spontaneously with their normal inhalation device. It was a deposition from 20 to 95%. On average, 50%, but high variability. He could reduce the variability when he asked the patient to inhale a certain volume, here 1 liter, with different flow rates. And the best was slow and deep. Sorry to say this, like a cigarette smoker. Cigarette smokers are trained to inhale their cigarette to optimize the nicotine content in the deep lung. So they suck on the cigarette, make a deep breath, hold the breath, and exhale. Perfect. And now look at an asthma patient inhaling with an MDI. You see the difference? I hope so. Slow and deep breathing. So I founded the company Activero. We developed different inhalation devices, and we focused on helping the patient to inhale deep and slowly. This was our main effort, to develop an inhalation device that trains the patient, that help the patient to make the correct breathing pattern. We sold the company successfully in 2014, and since then I came back from pharmaceutical industry, back to research. And then this happened in 2020. And I remembered a study that we did also in the 1980 when I was in the lab together with Willi Stahlhofen. It was an interesting study we did, and I show you this study in a minute. But before I do this, I show you these two statements. This was a big surprise for me when the World Health Organization had on their website a statement that says SARS-CoV-2 is not transmitted by aerosol. And the second statement was, and this was, I was upset when I read this, an aerosol is a droplet nuclei smaller than 5 micron. So we are aerosol experts. And not a single expert in the world raised the hand and say, stop, this is not an aerosol. This is an aerosol particle, what you are describing here, but this is not an aerosol. An aerosol is a suspension of gas and non-gaseous particles. But now coming back to the other statement, SARS-CoV-2 is not transmitted by aerosol. And I was surprised about this because it was some of my friends, medical doctors, they told me about very serious deep lung effects of these patients. They had really, really bad deep lung and infections. And I said, hey, how can a virus which is transmitted with the hand go into the deep lung? If I would be the virus, I would be transmitted via an aerosol because it's easier to get into deep lung. And I remembered a study we did in the 80s in Frankfurt, I said it already, the origin of these aerosol particles. We did a study where we asked volunteers to breathe normally, to breathe clean air, and the lung works like an aerosol generator. So we could not stop particles measuring in the exhaled air. And then we asked we looked at these particles and we did a lot of studies about this. So we found that the size was about 2.3 micrometer. We could not find an increase of this particle amount with flow rate. It was when we made a breath hold, the amount of particles that you exhale goes down. So that shows us these particles are generated during inspiration, not during expiration. With a residual volume breathing pattern, we could increase the number of this exhaled particles significantly. Intersubject variability was high. Particles were not detected in the first breath, part of the breath, but at the end. So our conclusions was the particles were not generated by shear forces. These particles are generated during inspiration. These particles are exhaled from the deep lung, and the effect could be the reopening of collapsed small airways. And here I have a small video that can demonstrate this. So if the small airways are collapsed and they open during the breath, then a small amount of surfactant goes into the alveolar space and is exhaled during the next breath. It's exhaled and it's getting out of the lung again. This effect is now there are a lot of experiments and many researchers in the world, they already found this same effect. We did a study in SARS-CoV-2, in COVID, where we measured adults, healthy volunteers, and patients in the hospital with SARS-CoV-2. And normally normal patient, when we are sitting here in the room, we are exhaling about 200 particles per liter. So it's a very small fraction. It's a very, very small number. But when patients got an infection, about 15% of patients exhaled more than 5,000 particles per liter. So that's a much higher number. We found patients with more than 100,000 particles per liter. This is a factor of 100 more than normal. And these patients, we call them super spreader. There was 15% of the patients were super spreaders, and they transmitted this virus much more efficiently than the 85%, which exhaled only normal particle numbers. And we repeated this study in children. Children exhale much less particles. And we found not a single, we did hundreds and hundreds of experiments in children. We found not a single super spreader in children. So what do we learn from this? We learn that that children transmit this virus less efficiently than adults. So transmission of SARS-CoV-2 as an exhaled aerosol, yes, there is sufficient evidence now. There are published studies, 100 of published studies now. My feeling is there are 2 ports of entry for SARS-CoV-2. One is a nose. If this is the main infection site, the disease will be mild. That was the later versions of this virus. And at the beginning of this SARS-CoV-2 infection, the alveolar region was infected by tiny aerosol particles, and then you have a very severe disease. Aerosol particles can be generated by breathing. Sure, they can also be generated by speaking, sneezing, coughing, and so on. Not every infected person is infectious. So there were reports at the very beginning of the corona crisis that people living together with their husband or with their wife, and they were not infected, despite the fact that the other spouse was very infected. Adults exhale significantly more particles than children. I think that's something we should realize now for the next, hopefully not as soon, corona crisis. After 45 years in aerosol medicine, yes, I have now another lesson learned. Be curious, yes. Be critical, yes. But also be brave and take a chance. And that's what I hope to wish you all. If you are a young scientist, be curious, be critical, but also be brave. And I want to stop with this slide. Success is a child of audacity. Thank you very much for your attention.
Thank you, Gerhard, for that wonderful talk. And I love the way you provided a timely reminder that particle size is not everything. Because I think even to this day, some people think that MMAD is an absolute predictor of lung deposition. And clearly you've made the point about breathing pattern is very important. And of course, where is the position of the tongue when people are inhaling as well? So it's another factor. Good. So folks, questions for Gerhard, please. Anybody? Oh, there's one there. Do we have a microphone person? We do. There's one over there. Oh, there's one here as well. We'll be with you in a moment. Okay. All right, well, we'll start with this one and then we'll come back to you.
Hi. Oh, sorry. Hey, Gerhard. Nice to see you. Can I be super critical on what you just said at the very end, where you said tiny aerosols were the reason for getting this deep infection in SARS-CoV-2? But I'm sure you're aware that SARS-CoV-2, the early versions at least, went through the ACE2 receptor into the cells. And these are found only in the alveolar part and a little bit in the vascular system. So I think that was the key of transmitting in a deep lung.
Yeah.
So it's not the tininess. Yeah, you were hitting on the size being not so relevant. I think this is the case here too as well.
Yes, you're absolutely right. But these receptors are in the entire respiratory tract. They are in the nose. They are also in the deep lung, and they are especially in the deep lung. And in the deep lung, you're absolutely right. Where the SARS-CoV-2 is then replicated, and by this replication, more surfactant is getting into the small airways. There's more airway closure, and this brings more particles out of the lung. And this is a very efficient system and a very efficient mechanism how these viruses are transmitted. Yeah, thank you.
Question over here, please.
So if I had to make an educated guess that Otmar, you'd precede me in asking a question. Yeah, I'm over here to the other side. I'm arguably one of your biggest fans, and if this crowd hasn't understood how profoundly you were ahead of the curve in 2020, you had a paper about 8-9 months ahead of what the WHO was acknowledging. I mean, it was a landmark piece. So I can't understate how important you've been to the field. But I have to counter-argue what you just said, because in 2020, there was a very seminal paper in Cell that talked about a so-called ACE2 gradient. And in fact, most ACE2 receptors for SARS-CoV-2 are in the upper and extrathoracic airways, which shocked me. And so the theory was most people would get a mild condition because the probability of the position was mostly up. And there are these theories of what connects to what you said, which are so-called, for lack of a better word, reaspiration. And the idea is that, as he said, you inhale, you deposit here, but you re-inhale and resuspend aerosols from your own self, which means that if you're infected in the top, you can infect yourself eventually in the deep airways.
By your own inhalation, you get I understand.
And so anybody who knows
but the replication is in deep lung?
I don't sufficiently know, but nobody has had a harsh harsh COVID with the so-called SARS, right? I mean, with the so-called, ARDS or whatever type of ARDS, if you're not infected in the deep lungs. There's no ARDS based on upper airways.
But how do you explain then that people, there were experiments, they found more viable viruses in small particles than in the large particles. So in the large droplets,
I don't know, I'm not the biologist here, but I think the interplay between the physics of the aerosols and the viability of the virons, so to speak, they work in pair. But it's crazy that you can basically infect your own self in the harshest way. But just to commend you for all the years, I think you're an inspiration to the field. And I'd like to be an advocate in making sure that point is passed on. So thank you.
Okay, I think we have time for one more question. I think another one just down here, please.
Thank you, that was really interesting. I was wondering, are there any causes you could find for why an individual in the population would be a super spreader as opposed to generating very few aerosols?
What? I couldn't.
Sorry. Did you find any causes as to explain why an individual in the population would be?
No, it was totally arbitrary. So we could not find a reason for this being super spreader or not. So it was arbitrary. So this is something I think people should work on, and it's a part of the virus replication that we don't understand quite now. So hopefully we will understand it in future. But it was surprising that not every and these people in the hospital, they were seriously ill, and they were not super spreading. So some people didn't exhale more particles than a normal, not infected individual, and we don't know why this is. We have no idea.
Okay, wonderful. So please join me, folks, in saying thank you again to Gerhard.